Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 21th topic. Occlusal splints. 21. Occlusal splints. Contents. 1. What is occlusal splint therapy? 2. Features. 3. Side effects. 4. Types. A. Anterior occlusal splint. B. Full arch occlusal splint. C. Mandibular protrusive occlusal splint. D. Posterior occlusal splint. Summary. 1. What is occlusal splint therapy? Occlusal splint therapy, also known as a bite plane, is an occlusal treatment that establishes a temporary occlusion by interposing a synthetic resin device between the teeth of the upper and lower jaws. Its therapeutic effect is immediate, as it can instantly establish an appropriate occlusal relationship. On the other hand, it is also worn to temporarily reconstruct the occlusal surface for patients, such as in the case on the right, where the cusp-to-cusp contact position is significantly displaced from the centric relation. 2. Features. Occlusal splint therapy is considered a reversible procedure because it does not require reduction of natural teeth and allows treatment to be easily interrupted by removing the appliance. Furthermore, since it is adopted as an occlusal elevation splint under dental insurance, it has become quite widespread. However, with the exception of some splints, its fabrication is complex and not straightforward, as it necessitates forming an ideal occlusal surface based on advanced occlusal theory. Specifically, occlusal splint therapy is a treatment method requiring the following steps. Based on the patient's occlusal analysis and diagnosis, predicting the appropriate occlusion suited to the patient, and then constructing the target occlusal surface on the occlusal splint. Occlusal splint therapy performed without proper occlusal analysis and diagnosis is also a treatment method with significant side effects, potentially causing irreversible damage to the temporomandibular joint. 3. Side effects. When a properly occlusally adjusted occlusal splint is fitted, patients immediately experience symptom improvement, reporting that biting feels easier. If no symptom improvement is observed upon fitting, the splint's occlusal surface must be adjusted immediately or the use of that splint discontinued, requiring the fabrication of a new splint with an appropriate occlusal surface. If a patient complains that their symptoms have worsened, suspect that the occlusal surface of the occlusal splint contains malocclusion and immediately discontinue its use. Persisting with use under the assumption that it will improve if endured, forces the patient to use an occlusal splint with an incorrect bite. This can lead to irreversible damage to the temporomandibular joint, such as degenerative temporomandibular joint disorder or damage to the posterior disc tissues. 4. Types. There are the following types of occlusal splints. A. Anterior occlusal splint. B. Full arch occlusal splint. C. Mandibular protrusive occlusal splint. D. Posterior occlusal splint. Each will be explained below. A. Anterior occlusal splint. As shown in the photo and illustration on the right, an occlusal splint for anterior teeth only is fitted to the maxillary anterior teeth. The guiding surface of this appliance is formed parallel to the occlusal plane. Contact of the mandibular anterior teeth with this guiding surface causes the molars to separate, eliminating molar occlusal interference. Consequently, symptoms caused by molar occlusal interference improve, and the lateral pterygoid muscles gradually relax. Once tension in the lateral pterygoid muscles is relieved, centric relation guidance of the mandible becomes easier, leading to more accurate occlusal analysis and subsequent treatment. Therefore, an anterior occlusal splint is an examination appliance used for occlusal analysis, diagnosis, and treatment in patients where obtaining the centric relation is difficult. A. Anterior occlusal splint. An occlusal splint for the anterior teeth only offers the advantage of being easy to fabricate and readily guiding the mandible to centric relation by temporarily eliminating occlusal interference in the molars. On the other hand, a disadvantage of this occlusal splint is that prolonged use can cause molar extrusion, making it easier for new malocclusions to develop. Therefore, the usage period for this splint is typically limited to about 30 minutes to 1 hour, and should not exceed 2 to 3 days at most. As an alternative to the anterior occlusal splint, rolled cotton can be used. As shown in the right illustration, placing 2 rolls of cotton between the left and right canines allows temporary guidance of the mandibular condyles to the centric relation position, serving as an aid for examination and diagnosis. B. Full arch occlusal splint. As shown in the illustration on the right, a full arch occlusal splint is typically fabricated to cover all teeth in the maxilla. The occlusal surface of this splint must be precisely shaped so that all mandibular teeth make stable contact at centric relation, and during eccentric movement, the mandibular anterior teeth glide smoothly over the splint while the molars immediately disengage. The advantages of a full arch occlusal splint are that it can prevent tooth extrusion and is suitable for long-term use. Therefore, this splint is used after disc reduction to prevent disc displacement and to facilitate the recovery of the posterior disc tissues. B. Full arch occlusal splint. Full arch occlusal splints are fabricated by waxing up on a model capable of reproducing occlusal movements, mounted on a semi-adjustable articulator using a face bow. Methods such as fabricating by pressure bonding a uniformly thick vinyl sheet to the maxillary model, or using a mean value articulator without a face bow, are not suitable for fabricating full arch occlusal splints. The reasons are as follows. The occlusal plane of patients with malocclusion typically exhibits some form of morphological abnormality. Splint therapy is performed without addressing these morphological abnormalities of the occlusal plane. The occlusal surface of the splint corresponding to these morphological abnormalities is complex, making it difficult to achieve an ideal occlusion through intraoral occlusal adjustment. B. Full arch occlusal splint. When a full arch occlusal splint with an appropriate occlusal surface, as shown in the right figure, is worn, improper pressure exerted by the mandibular condyle on the articular disc and retrodisc structures is relieved. The articular disc and retrodisc structures gradually recover. As the articular disc and retrodisc structures recover, the position of the mandibular condyle gradually changes. As the condyle's position changes, slight malocclusion may develop on the occlusal surface of the full arch occlusal splint. To resolve this, occlusal adjustments are typically required every 1 to 2 weeks during the initial period of wear. Subsequently, as the articular disc and posterior disc structures recover and the disc stabilizes in position, the interval between occlusal adjustments lengthens, eventually requiring adjustments only about once every few months. Through this process, the compromised temporomandibular joint complex heals completely. Note that even if symptoms improve with the full-arch occlusal splint, this does not signify completion of occlusal disorder treatment. Removing the splint allows the patient's occlusion to revert to its original functional malocclusion state, causing the occlusal disorder to recur. Therefore, after symptom improvement through splint therapy, occlusal reconstruction based on occlusal analysis and diagnosis is absolutely necessary. C. Mandibular protrusive occlusal splint. As shown in the photo on the right, the mandibular advancement occlusal splint is a device that guides the mandible forward to reduce pressure applied from the condyle to the mandibular fossa. This occlusal splint may also be used to prevent snoring and treat sleep apnea by guiding the mandible forward to secure the airway. The occlusal surface of this splint is designed so that biting causes the mandible to naturally protrude forward. While short-term use results for mandibular advancement splints have been reported, long-term use of occlusal splints is generally discouraged. C. Mandibular protrusive occlusal splint. Dawson questions the effectiveness of mandibular anterior position-inducing occlusal splints as follows. Wearing this occlusal splint induces the mandible into an anterior position. At that time, the lateral pterygoid muscle contracts strongly. If the lateral pterygoid muscle contracts strongly, the symptoms may worsen. Furthermore, the role of this occlusal splint to reduce pressure from the mandibular condyle to the mandibular fossa is counterproductive, because the condyle is positioned on the slope of the glenoid fossa. Consequently, the glenoid fossa and articular disc cannot withstand the pressure exerted by the condyle. Additionally, since the closing muscles are located between the teeth and the temporomandibular joint, changing the point of action cannot reduce the pressure applied to the fulcrum. D. Posterior occlusal splint. As shown in the illustration on the right, an occlusal splint for molars only is fitted to the mandibular molars. Using this occlusal splint eliminates the guidance of the anterior teeth, which is essential for proper mandibular movement. Furthermore, prolonged use of this occlusal splint causes anterior tooth extrusion, resulting in severe malocclusion with mandibular retraction after splint removal. This occlusal splint does not provide patients with proper occlusal movement and has no recognized therapeutic effect for occlusal disorders. Summary. Recently, occlusal splint therapy has been evaluated as a reversible treatment and widely practiced as a trial therapy. However, for occlusal disorders, treatment should not be attempted without first performing occlusal analysis and diagnosis. All occlusal treatments are based on a diagnosis that clearly identifies which teeth, which parts of those teeth, and what specific malocclusion exists in the patient, and confirms that this malocclusion is the cause of the occlusal disorder. Similarly, occlusal splint therapy should only begin after selecting the type and method of splint based on a treatment plan determined by the patient's confirmed occlusal diagnosis. Just trying occlusal splint therapy for now is a dental treatment that should not be performed.